I mean, in terms of his reason for speaking, one is that he underwent kidney pancreas transplantation in 2001. In fact, I think he will tell us he had 2 transplants in the course of things. It will follow that his special interest is immunosuppressive therapy.
For sure.
Perhaps. I should mention that he's a retired forensic specialist and he's doubly qualified in medicine and dentistry. And his particular expertise was in the use of trace DNA evidence to solve crimes. So a sort of modern day Sherlock Holmes, I suppose. And what will be interesting to find out is what his evidence is that immunosuppression is a crime.
Okay. Well done, Mike. Thank you very, very much for the introduction. And I, like the other speakers today, want to express how excited I am to be here and how much I appreciate the invitation to not only be here as a speaker, but also to be a patient partner in the upcoming research. So good afternoon, colleagues, friends, and guests. As you've heard, I'm David Sweet, 2001 kidney pancreas recipient from an obviously a deceased donor. And I will die in 3 years. A direct line can be drawn from HLA tissue matching and immunosuppression to this eventuality. And I'd like to take this opportunity this afternoon to draw that line for you or help you to understand that line. Since 2001, I've been taking 3 immunosuppressive drugs, tacrolimus, mycophenolate, and prednisone. In fact, back in 2001, Dr. Paul Keon was my clinical nephrologist, and I am certainly the better for his most excellent care and absolutely outstanding attention to details. Unfortunately, I lost my 2001 kidney graft about a year afterwards in late 2002 to polyoma B virus infection. I underwent a nephrectomy. I was back on hemodialysis until January 2004, and then I received a new graft from a living, non-related donor, a very dear friend, to state the obvious. So this year I celebrated my kidney anniversary 20 years, my 20th birthday, and my pancreas anniversary 23 years. Yay! As you know, immunosuppression is a drug or are drugs that attempt to fool the recipient body into thinking that the new parts that it's received are not its own and they're okay. The recipient body doesn't have to try to reject or fight the new tissues. I've had no kidney rejection episodes, despite being an HLA tissue mat at approximately half of the comparison points with my donors. Half the compared points, because immunosuppression can cover up such mismatches and continue to fool the immune system. And obviously, this has been our approach over the previous years until the exciting things that are happening now in transplantation medicine. What I want to say is that these are hugely complex and strong drugs, and they have enormous, frightening, and life-altering side effects. Incredibly, it appears that they foster the development of and the growth of malignancies. For example, post-transplant, I've had many, many squamous cell and basal cell skin lesions. N equals 91. and they've been excised from virtually everywhere on my body. My skin looks like the roads on the map of Scotland from the scar tissue. These lesions are believed to be caused by at least tacrolimus and possibly tacrolimus in combination with mycophenolate. Long-term prednisone is no fun either. In 2011, I beg your pardon, I see what I'm doing now. This touch screen is reacting below my papers. In 2011, I was diagnosed with stage 4 adenocarcinoma of the distal esophagus. That was 10 years after I started taking the immunosuppressive drugs. This adenocarcinoma was thought to be directly related to the immunosuppression. I had 8 weeks of intensive chemical warfare, how I refer to chemotherapy, plus I underwent a 2-hole esophagectomy, or gastric pull-up. For those that don't know, a gastric pull-up involves the complete excision and removal of the native esophagus, plus the top 1/3 of the stomach. Pick a surgeon with very long fingers. 2 incisions, a hockey stick-shaped one in the neck and a large one in the belly. The middle third of the stomach is then fashioned into a new tube, pulled up into the throat, and reattached as a replacement esophagus, leaving about 1/3 of the native stomach for GI function. Dumping syndrome, nausea, vomiting, a lot to deal with post-op, and certainly through the years until today. In 2012, a year after the initial treatment, a metastatic adenocarcinoma was again found, this time in my throat, at the anastomosis site. It was apparently present in the stomach tissue that the tube was formed from and brought up into the throat. I was told by the thoracic surgeon that this large tumor was inoperable because of its position, and that there was nothing more that could be done. I should get my affairs in order because I would probably die within about 6 months. So that would be October of 2012. I survived that adenocarcinoma, as you can see. It was a combination of a further 8 weeks of systemic chemo plus focal radiation to the neck. It was an aggressive cancer and it grew very quickly. So my medical and radiation oncologists also got very aggressive, but following radiation, I have leftover esophageal mucositis plus post-anastomosis, surgical anastomosis. I have scarring at the site that requires at least once or sometimes twice yearly dilatations under general anesthetic. All the same, what a life I've led for the past 23 years. I know I sound critical in some ways, but certainly that's not the case. I'm very thankful. During my time post-transplant, I've enjoyed a wonderful and satisfying career in forensic science, with productive research at my lab at UBC focused on trace DNA evidence from heinous crimes and taking conclusions from the analysis and that opinion evidence to various courts around the world in some pretty high-profile cases. Along with a dedicated team in my lab, like all of us enjoy, new analysis methods using smaller and smaller amounts of evidence have been able to be developed here in Vancouver and shared with police laboratories around the world. So I've enjoyed roles that are incredible when you think about it. I was the chief scientist for disaster victim identification at Interpol in Geneva. I've been a forensic advisor to the International Committee of the Red Cross. In hindsight, it was my transplants that first generated these opportunities and made it possible for me to open my mind and truly problem solve in an unfettered way, separate from end-stage renal disease and type 1 diabetes. Then, in June of 2023, that is the summer before the last one, I was diagnosed with stage 4 metastatic squamous cell carcinoma of the skin of my chest, with mets already present bilaterally under my arms and most likely further afield. After many attempts at various treatments and consideration of several other treatments in light of DNA testing that was done on my tumor cells, it was determined that the best way forward would be immunotherapy, targeted therapy with cemiplimab. There's one problem with cemiplimab in a patient like me. 24 days after I started my first dose, I would lose through rejection my 2 grafts, both my pancreas and my kidney. That was something that I would not accept because of their precious, the way I think about them so preciously. So this time again, my supervising oncologists have explained to me that there's really nothing more that can be done. And I was placed on palliative care last September, so a year ago, and my life expectancy was at that time about 4 years on average. All of that is background for me to try to relay to you why I started this talk with "I will die in 3 years," at least statistically speaking. This is now my average life expectancy given the aggressive nature of this new cancer, and it is also thought to be from the immunosuppression drugs. So we're all at this symposium to hear the latest in research and the way forward, talking about epitope tissue matching and certain aspects of precision medicine, in organ transplantation. I, for one, and I think I speak for most, if not all, potential recipient patients, that I find this extremely exciting and that it gives me great, great hope for future transplant recipients. I encourage you all to keep moving in this direction because the future based on transformative tissue matching, such as using epitopes, could potentially remove the need for immunosuppressive drugs, these highly problematic things that have caused me so much trouble, or at least to use them in very low doses. Wouldn't that be disruptive? In fact, it would be revolutionary. I hope that sharing my personal comments with you has been insightful and that they may provide you with some food for thought. Thank you.
Questions for David?
David, I don't have a question, but I only wanted to say thank you for your words, and it's been wonderful working with you over such a long period of time. It's truly been a pleasure. We're delighted that you're going to help to guide us on this next step. And we hope you'll be around for the grant after that as well, because I've already put your name down for it.
Paul, I've been a street fighter for many, many years. I grew up playing lacrosse, hockey, baseball, very competitive. And when somebody says you can't do something, that's all I need.
That's what we want.